I hear this all the time. This isn't just like something that I hear from pet owners, but just from people in general, where they'll say, oh, I took this drug and it wasn't strong enough, so I'm taking the stronger one. And it's a totally different drug from a totally different category of drugs. And I just wondered if you could explain why we haven't got a scale of what I like to call crap to good medication, pain relief medication. There is actually different categories and they all work in different ways. And I wondered if you could cover that in an easy way to understand. If there is.
Yeah, we all look for that magic best drug. And I think if you look at it rationally, there is no best drug. So we get something that's known as potency or how effective a drug is, for example. And potency, by the way, doesn't have a lot to do with clinical efficacy. It has a lot to do with how much we dose. Mm-hmm. So, for example, if you take something like LSD, for example, you need nanograms and you can start hallucinating on it. So it's incredibly potent. But you may need to eat a few mushrooms to get the same effect. So you're going to eat milligrams of a mushroom to get those hallucinations. And that sort of does describe what potency is. We get highly potent opioids, for example, like fentanyl, thiofentanyl, for example, which are 1,000 or more times potent than morphine. What it means is we just dose these drugs in incredibly small amounts. So we often get confused between that is potency, which just means of how much of a drug we give. And then we try to say, for example, that non-steroidals are a weak analgesic and opioids perhaps are a more potent analgesic or always work. But it's like comparing apples and pears together because they work through entirely different pathways. And it depends what's motivating or what is causing your pain, for example. So as I said to you, opioids, you still feel the pain, but you don't care about it too much. Yeah. They change your motivation and your response to that pain. But if you've got a strong inflammatory pain, so it's all driven by inflammation and inflammatory mediators, opioids do nothing to stop that or alter that inflammatory response. A drug like what we call a non-steroidal anti-inflammatory drug will alter that response. And in some of our patients, it's far, far more effective than what an opioid is. Will an opioid work? The answer is yes. And we're guilty of that in veterinary medicine. We've done a whole lot of studies comparing opioids and non-steroidal anti-inflammatories against each other with entirely different mechanisms. So we've set ourselves up for that own failure in a way to say, oh, but this works just as well as that, or they're equally effective. Yeah. And it's not always true that that is the case, that it is, because it depends on the type of pain you are experiencing. But the best pain or pain effects you can get, for example, if you look at acute pain, something like going for surgery, is to combine a non-steroidal and an opioid together because you get far better analgesia after your surgery out of that combination than either of the drug on their own. Yeah. And clinically, we don't do that type of research, sadly, because when manufacturers bring out new medications, they want to prove that their drug's the best, if I can put it to you that way. Yeah. And they don't want to do research which says, well, our drug works really well if you use it with a whole host of other drugs. There's a guy, Charles Natterson, who started a lot of this research, but he said, I don't know whether our audience probably won't even care about ventilation, for example, but there's this whole thing that you use low tidal volume ventilation is good, high tidal volume ventilation is bad. And he said, hold on, there's this other group of patients, we treat them clinically. And what he actually found out about is the least number of patients died in the clinically treated group, but their tidal volumes are actually very close to the high tidal volume. And that's because we change our therapy to what our patients need. Yeah. And we adjust that therapy and we play it. It's like playing a musical instrument. You fine tune it and you make little changes all the time to give that patient the best outcome. Yeah. And that uses multiple drugs. So I don't always look at drugs as being poor or weak or good or strong drugs. Paracetamol, for example, has had a very strange history because some of us view it as a non-steroidal anti-inflammatory drugs. People wanted to take it out because they say it has no anti-inflammatory effect, which is true. If you look at sites of inflammation, the concentration is incredibly low, but you still get pain control out of it. And that's where we discovered that paracetamol actually works within your brain and your spinal cord. Yeah. Does it give you as good an analgesia, for example, if you take paracetamol and compare it in humans to ibuprofen or one of the other non-steroidals, it's true. It gives you just as good as analgesia out of it, although it's not going to affect inflammation very much. And there's another like combination which in human medicine they do use is to use, for example, paracetamol and ibuprofen together. And there's a number of those combinations available. And we can't use it in cats. Don't ever give your cat paracetamol because paracetamol kills cats. It's always important to give that warning because people think, oh, I can go and give my cat some Panado. I don't know whether you guys have Panado, but we do it. But Panado will kill your cat. So don't give your cat Panado. But dogs cope actually very well for paracetamol. It's one of the reasons that paracetamol is not available in veterinary medicine is because there is a fear that people will accidentally give it to their cats. But in some dogs, it works really, really well.
Yeah.
And you can combine it with another non-steroidal, and that in actual fact is fine. They don't need an opioid with that type of combination that is there. And as I say, that to me is the effective thing. If we start to look at severe pain, even opioids, you need to give massive doses to control it on its own. So we often use other drugs to get synergism out of that to give you the best pain control. And as you give more doses, or the higher your dose, for example, you get more side effects. So opioids, eventually you'll go to sleep, stop breathing, which is really bad if the doses get too high. So we've got to be aware of that. And there's a trade-off between side effects and benefits, if I can put it to you that way. So sometimes what we consider potent and giving them at high doses will control your pain, but with large side effects. And that's not useful for owners either. Most owners want a pet that you interact with. You can goes with walks with you, comes for cuddles on the bed, jumps up on the couch, whatever those things that you needed to do. And it's about giving that back to owners. And so I often look at those scores, for example, as the HHH-MMM score, which is used in cancer patients. But I look at those in osteoarthritic patients because it's useful for owners to decide about hurt, hunger, can they go out to urinate, defecate, all those type of things that are actually looking after themselves. And it's about quality of life.
Yes.
And as I say, I use the drugs to optimize that. It's not about which drug's stronger or weak or poorer. Potency doesn't play a role. It's just I get to choose different doses then.
Yeah.
That it is there, but it's actually what benefits that patient the best.
Yeah.
And that's unique. And it sometimes takes a lot of playing to get it right for one dog. And the sad part to this recipe is, and we all would love that, is to give a single drug that works in all our patients. And that's not the case. It doesn't work like that. Even opioids will fail. We've talked about, for example, tramadol will fail. Morphine can fail. Fentanyl can fail. All the high potent opioids can also fail in providing us those analgesics, although many people would consider them stronger, for example. Just from a historical point of view, where this also comes from, codeine has always traditionally been considered a weak opioid. And part of that reason is it's dependent on metabolism to the active metabolite. So it gets metabolized to morphine, and that's often rate limited. So you have a maximum effect out of how much codeine you take. And therefore, if you compared codeine to morphine, for example, you can get a lot more analgesia out of morphine than it is. And that's sometimes where this concept of weak to strong opioids came from. And that's in the World Health Organization in their pain ladder that came from. That's often where the concept came from. But that was, for example, treating cancer patients, where you start off on simple drugs. And as the pain increases over time, you go up and you're giving more and more potent opioids that you can titrate clinically to effect. And a drug like codeine, for example, has a ceiling effect. So if we looked at opioids, we could say that of the opioids, they can be weak or strong opioids because some of them have a ceiling effect. And it's that ceiling effect that limits their effectivity. All non-steroidals, for example, have a ceiling effect. Giving more often doesn't improve clinical benefit. All it does is increase side effects. So giving more of a non-steroidal anti-inflammatory doesn't help us.
No.
We're lucky that there's reasonable evidence out there to say we can titrate down doses of non-steroidals to try and get to the lowest possible dose to keep that animal comfortable. But giving more than the maximum doses is often not going to give us any more benefit. Yeah. So it has a ceiling effect. And some people use that concept of drugs that don't have a ceiling effect as being the strong drugs. So
Yeah.
We just use a lot of morphine in our own country because it's cheap, or fentanyl. But I can just keep on titrating it, and eventually you'll go to sleep and you'll be fast asleep, etc. Yes, you won't have any pain, but you're also not functional.
Yeah.
And that's never what we're trying to achieve in our patients. I want functional patients that walk around and run, and exercise.
Yeah, absolutely. All about quality of life. Again, it always comes back to quality of life, doesn't it? So I think you kind of discussed what we were going to say about non-steroidals versus opioids, weren't we? You were going to say about, you said there was a study to do with paracetamol and tramadol?
There are, well, even in the human market, paracetamol and tramadol are sold as a combination. There is evidence to show, certainly in humans, that you get a synergistic analgesic effect with the two of them together. So in other words, more than what you'd get with either drug on its own. But that's true of non-steroidals and other opioids, that you get additive or synergistic, which means you get more than 1 + 1. So 1 + 1 now becomes 3 or 4 instead of 2 by combining these drugs, because you get synergistic effects with it. That's out there. For example, drugs that block NMDA will also improve opioid analgesia. Gabapentin, for example, which is one of our, also I always call them alternative analgesic drugs because they're not direct conventional analgesic drugs, also has additive or synergistic effects with opioids. So it improves pain control for us to use those combinations. And to me, to be honest with you, drugs is one component of that therapy. As we said, we've talked about them. You can go through some of the alternative therapies, which are benefit TENS, which we haven't talked about. Transcutaneous electrical nerve stimulation, it's often done by the physiotherapist, can be tremendously beneficial in patients. And it's also to find the non-pharmacological treatments, which are of benefit to patients. Longer courses of non-steroidals have been associated with better reductions in pain. So if you look at the pain curves, for example, and Firocoxib, which is Previcox, published that study where it was given to geriatric dogs over a whole year. And you notice that over the whole year, the pain scores come down. And there's evidence for that for most of the non-steroidal meloxicam, for example, and the other non-steroidals that are there. And part of that reasoning is that osteoarthritis is an inflammatory joint disease, and we get flare-ups of this inflammation inside joint, which leads to further cartilage destruction. And by reducing those flare-ups, we may be able to save cartilage, but also reduce the flare-ups. And if you look at also that data, for example, in chronically painful patients, a patient who's been painful for a short period of time responds a lot quicker versus a patient who's had pain for a year or so, and they take a lot longer to respond for. So how long should that first course of non-steroidals be? And some vets, for example, will give a week's worth, 10 days. That's it. Should we give a month's worth? Should we give 3 months worth? Should we give 6 months worth of the drug? These are questions that I can't quite answer now for you, but we know that it has impacts on that joint inflammation and how pain scores come down, for example. And then we know that pain scores will come down with longer courses. And of course, that opens up the question of safety, which they've also been looking at and looking at that evidence as well.